Perfect. Okay. Well, so thank you all for the chance to talk with you. I'm actually particularly interested in the dialogue because, as you're going to see, most talks that or most projects that I do as a physicist working on energy are they may be complex in their doing, but they're designed to be fairly kind of linear in how things put together. This is not. This project is multifaceted in ways that are fun, but mean that kind of explaining who, what, and why we are takes far longer than it normally should. So I'm going to really be keen on much more of the discussion side. So if I can do one last thing, I'm not seeing the bottom of my slide set. Um, I can share screen fully. Right now, it's not. I have a very curious something on my screen here. Give me, sorry, 1 second. It's not letting me, there we go. Okay. You hopefully see a cover slide now. Is that, okay,
Yeah.
great.
Yeah.
Okay. So couple key acronyms just to get started. This talk is part of something called HETA, which is the Health, Electrification, Telecommunications Alliance, and I'll explain the plus in a bit. And I'm again a physicist who has worked on energy access. As Jatin noted, we've worked together on a variety of projects in the past. This one builds on two very different threads. One is that when I first moved into energy projects out of theoretical physics now 3.5 decades ago, my first effort was actually on cook stoves and health in central Kenya, in Laikipia district, which is just west of Mount Kenya, a very interesting, geographically diverse area. And what I did was kind of not simple, but maybe a natural entry point for a physicist. We looked at the health impacts of indoor air pollution and cooking. The technological tools were pretty rudimentary back then, but over 5 years, we built an exposure response curve for 500 households, so about 1,300 people total, um, cooking with a variety of fuels, from wood, dung, charcoal to liquid petroleum, in a quite rural community, and use that to build again. It wasn't an RCT, a randomized control trial. It was a natural experiment of who adopted which stove, and found a very striking exposure response relationship. Kind of every time you could drop the pollution levels from ambient inside people's homes to about a third of that, you got a significant, like a 50% reduction in a couple forms of pneumonia. So it was a wonderful introduction, kind of very data intensive. And so this project is anchored back in that same county in Kenya, but as you'll see, it has a Pan-African reach. And I've highlighted both myself and then Ms. Nancy Chege, who is the co-convener of this project. She is the Kenya country manager for the United Nations Global Environment Facility Small Grants Program. Has been that for about 15 years. And I'll bounce back and forth between the energy side and the community ethnomedicine side a little bit in the comments. So I don't think I need to dwell on, but I just put it in just to highlight for those who don't think energy and climate every day the way Jatin and I do. And that is that we are very much not on pace to meet our climate goals. That probably doesn't surprise anybody. The rate of decarbonization, which has ticked up, it's gotten better in the last little bit, with the European passage of the various carbon and climate standards, notably Europe 2030, and in the United States, the Inflation Reduction Act, that essentially doubles our rate of decarbonization from kind of an anemic 1 to 2% a year to, if everything in the IRA goes forward, to perhaps 3 to 4%. And it means that we would be on the order of 40% below our current emission levels by 2030. China has a similar package, although China's is more chaotic. They are the global leader in manufacturing decarbonization technology, notably solar and wind and energy storage and electric vehicles. But they're also building more coal plants than the rest of the world combined. And so they are very heavy on the good and very heavy on the problematic side. And then some countries count nuclear. Some places don't as part of the mix. So we're not anywhere near our climate goals. Again, no surprise, I think, to this group. At the same time, we are not on track to meet our sustainable development goals. And in fact, we are in some ways worse off in meeting the goals of universal energy access, universal health care, equitable access to education for women, protecting biodiversity on land and the sea. So when you look at how on track we are, it's a paltry 15%. And if we kind of flesh out that picture across all of the SDGs, I don't expect you to know them by number. SDG 7 is where Jatin and I sit on the energy side. SG P 3 is health. They go on and on, but it's a really poor record. So the question is, how can we leverage our two failings to do better? And normally two wrongs don't make a right, but in this case, I'm going to argue a little bit that there's an opportunity to do better. So it's really a spiral out from SDG 7 on energy to a wider set of impacts. And that's largely because in a couple areas we are doing fairly well on the technology side, not necessarily on the deployment side. So in particular, the two fundamentals that are going to be really impressive here is that the cost of solar power has dropped by over 90% in the past decade. And that's building on a interesting learning curve of technology and deployment to the degree that solar, unbeknownst and I think not believed by many, despite the data, solar is now the lowest cost form of new energy generation you can install. And there are utility experts who don't believe that. It's truly the case. And the wonderful encapsulating statement that Bloomberg News has been running with now for 3 years is that it's now cheaper to build a new renewable energy power plant than it is to simply operate an existing fossil plant. And that comes with a lot of disbelief out there, but it's actually true. There aren't that many caveats to that statement. Doesn't mean we do it at scale. And just to put it in perspective, 2023, 2022, and 2021, solar and wind are more than 80% of all new generation capacity across all technologies installed worldwide. So there is a wonderful technological revolution. It's just too bad we're not following it up with policies and widespread deployment and a variety of features. But there is a wonderful technological underpinning story, and that's where I won't speak for you, Jatin, but that's I would say that's where you and I come from in terms of thinking differently about why the climate change story is not all doom and gloom. This particular project is really a way to try to leverage that story in Africa to deal with a ongoing and expanding health crisis. And I always like to put this graph up, not that it's directly relevant to the talk, but I find that few people, myself included, recognize just how remarkable the Mercator projection injustice is to Africa in terms of its extent. Africa will almost certainly be the second most populous continent by 2070. It's kind of a remarkable issue in healthcare and coverage and quality of life really suffering. So what is and where did HETA come from? It's something that we started when I was at USAID. And it is an alliance. It's not a government program in US government terms. It's a GDA, a Global Development Alliance, meaning that US government, USAID, put in the first tranche of money, $50 million, which is essentially nothing. But this large partnership that includes many of the UN agencies you'll know, but also Gavi, the Vaccine Alliance, and PEPFAR, President Bush II's effort to work on AIDS and HIV in Africa, a variety of other governments, the Danish government, a number of others, but then also a range of private sector actors, big corporations, GSMA and Orange in the cellular tower space, Bechtel, engineering firms, Rolls-Royce, and then a number of university partners, my laboratory at Berkeley, the Renewable Energy Laboratory, Arizona State's global development programs, kind of a variety of players. And the politics and connections are a whole nother story I'm not going to bore you with, but one piece that will be relevant is that we did fairly well in the first 2 years of raising money for this effort to electrify health clinics, so much so that Rockefeller Foundation put in $1 billion, and Bezos Earth Fund put $1 billion in, and IKEA Foundation put $500 million. And that's managed by a group I'll mention later on. They're called GAP, the Global Energy Alliance for People and Planet. They're housed in Rockefeller in New York and in Nairobi, and they have their own effort. They manage their monies quite separately, so we don't draw directly on that $2.5 billion. But of a price tag of about $5 to $6 billion to do what I'm going to talk about, there's actually some large new players out there. So what I'm going to focus on is health. What GAP is focused on is more broad, but we are partners in this kind of effort going forward. And the goal of this effort is to electrify 10,000 health facilities by the end of next year. We will almost certainly be over that. And ultimately, the goal is 100,000. And I'll explain why 100,000 in a second. So this is a kind of a strategy program where the money came fairly quickly to it, not enough, but a pretty hefty start. And it's really an effort around building an alliance on the planning side, but taking advantage of not only these cost declines I mentioned for solar, but also for batteries, and the critical role that health clinics, from the very smallest dispensaries to the largest tertiary hospitals, play not only in healthcare, but also as nucleation points for communities, for other services, for businesses across much of Africa. And so here you kind of see from planning to some of the initial clinics that have gone in. This is a fairly large clinic in Eswatini, construction of a fairly large solar field using some of those funds, and then telecommunications equipment, et cetera, going into a package. And the goal here is to build both technical sustainability, financial sustainability, operational sustainability, and retaining the staff at these clinics, because in some of the initial trial countries, the training that's happened so far has actually resulted in some of the nurses fleeing to Europe and elsewhere for better paying jobs. So we have a team at ISPRA, which is the EU research facility in Northwest Italy, and in partnership with ISPRA, we at my laboratory at USAID have mapped out the health facilities across Africa. The blue dots are these health facilities from the smallest to the largest. The black line is the grid, and the lack of strong overlap is one of the arguments for basing this on distributed clean energy facilities at, again, health clinics across a whole range of sizes. So far, this is now 6 months out of date. I should update it. The effort has resulted in just under 2,000 of the health clinics being electrified and equipped with monitoring equipment. Again, our goal is, well, officially is 10,000 to be electrified, wired, connected in by the end of 2025. Our estimate now is that we will be more like 25,000 clinics connected both energy-wise and IT-wise. That doesn't mean that the reporting systems will be ideal, but it means that we're actually making reasonable initial excited progress towards this goal of 100,000. And again, it's everything from refurbishing existing facilities, clinics and hospitals that are already on the grid. It's sometimes backup power. They don't necessarily need primary power in areas where the grid's reliable. Here's an example of a company. This is a Italian, US, Rwandan company called Off Grid Box. They make a containerized solution. The solar panels come packed in the shipping container. All of the hardware and wiring, boxes of sensors come packed in here, along with water purification equipment, along with Wi-Fi generation, and then the container becomes the office of this mini grid that powers a health clinic. They could do anything, but these are, in this case, are being utilized at health clinics. I showed that one before. And so that's the HE components, the health and electrification. The telecommunication is designed to do something that I think 10 years ago, I would have been pretty worried was a good idea on paper if you're an electrical engineer, but a bad idea in practice if you're a health practitioner or someone else. And that is a pretty heavy integration of now very low-cost sensors to allow the monitoring of the cold chain. So here we see low cost is about a $9 sensor that reports back on outages, voltage, and frequency. And so here we see a power strip, one of these devices plugged in the back of the refrigerator in this clinic. And this one here is in Rwanda. And this very humble refrigerator is supposed to be maintaining the cold chain for vaccines. And quite a bit of the initial push came from an interest on the vaccine community to leverage their resources to do more than providing COVID-19 vaccines, to reach out more broadly in the health community. So the idea here is, again, I'll go back for a second, utilizing this mixture of more reliable green energy, energy storage, sensors to document that the cold chain is preserved, that the oxygen generators, that the baby warmers, that the centrifuges have power when they need it. And the challenging part on the administrative side is that what companies commit to in this process is verification-based payment of a delivery. So you do not get paid in advance for installing health clinics, for providing the O&M. You get paid generally 3 months in arrears. It varies based on the country, for documented, delivered, reliable power that powers the facilities. And so that's one of the reasons that on the chart I showed in the beginning, when I showed the players here, there's a number of large players, Bechtel, Orange, Caterpillar, big companies that are not generally known for their green footprint. We needed big players first because only they had balance sheets that would allow them to accept these contracts where they get paid after the fact. Small renewable energy startups, clinic programs couldn't go for that. So we got a number of big players involved first, and hence the large money. And so we have an interesting mix where, in this case, for these willing to play large actors, we have an interesting situation. So here is kind of an example. This is one of my own project areas, Eastern Democratic Republic of Congo. This is Goma, a city that can't seem to get a break, whether it's lava or rebels. They are generally in trouble. And this is the powerhouse at a 50-bed hospital in Goma. The initial power quality you can see in the top here, and this is voltage. So here we have voltage on their local grid with massive fluctuations, which immediately short out refrigerators, oxygen generators, baby warmers, etc. They were a guinea pig in an effort to build what is currently the largest mini grid that I know of in Africa. There's always changing. This is a very large scale one. This is a 1.3 megawatt system expanding to 5 because it's been so successful. But where you see the power quality before installation at the clinic was terrible. All equipment was essentially shorted out regularly. And since installation, there's been really not a peep in this very challenging city. Any of you who've been to Goma or Eastern Congo know this is not the easiest place to work. We actually did this work in partnership with Dr. Dennis Mukwege, Nobel laureate, Nobel Peace Prize laureate for his work on building hospitals specifically to serve women who are who have been victims of gender-based violence in Eastern Congo. So this particular solar and battery, you can see the solar in the center and the batteries are up front. This powers much more than just the hospital clinics, but the hospital was the anchor customer, and that this project now sells power to the neighboring parts of the Congo. Lots and lots of electrical data. I'm not going to talk about it in detail. I literally spend whole talks about it in my own world, but basically tracking power quality, reliability. This is a measure of outages that electrical engineers use. Just looking at the clinics across the area, some of the clinics that we've electrified, some have solar, very reliable ones, and some have outages of more than 500 outages during a year. So kind of a range of efforts in place. Now, all of that is just to give you a feel for where we've started. HETA is now active in 10 countries in Africa. I won't get them all right off the top of my head, but Nigeria and Senegal and the DRC, Eswatini, Malawi, Tanzania, Sierra Leone. We're on the cusp of having Kenya join, and Morocco I'm only counting 9. So that's HETA. What is HETA Plus? The idea here, what came out of a variety of community meetings that we had in Laikipia. This is the governor of Laikipia. That's the environmental officer, the energy officer, the chief economic advisor, the county minister of health, that's Miss Nancy Chege, the UNDP person I mentioned at the beginning here. And the conversation came out of an interesting set of dialogues, and that is that in a number of community meetings, everyone said they were in favor at some level of this HETA program if the hardware would work, but they were always concerned, or came up again and again, that if there wasn't an active mechanism to not make this reliant on only what I'll call conventional medicine or Western medicine or technology-based medicine, that the poorest community members, no matter how subsidized the hardware was, would be left out if traditional ethnomedicine was not part of the mixture. So integrating ethnomedicine is the plus in the HETA Plus. Here is a map of all health facilities in Kenya. There's just about 2,200. This is the map of Laikipia district where we'll be working. The dark area here is Mount Kenya. Not a lot of health clinics on the mountain. Here are all the ones that are ring around the outside of it. And our proposal to USAID, UNDP, and now we are looking for the bigger donors to go beyond the pilot phase, is to electrify all 130 health facilities in Laikipia with this network of both data collection, so we know which clinics are having trouble, so that we can hopefully minimize operation and maintenance costs, management, expansion of solar systems, et cetera, but also integrating in ethnomedicine. So we just had the first workshop on the ethnomedicine piece 3 weeks ago in Nanyuki, the capital of Laikipia. My partner when I was in government, John Ong, is listed here. He's the ambassador for HIV management. He is essentially the point person for the PEPFAR funds. A number of community leaders, in this case, someone named Ole Kounga, who runs an indigenous peoples group focused on biodiversity and ethnomedicine, county government of Laikipia. Here I am with the country manager for Kenya, Akeem Steiner, who is the head of UNDP, based in New York, but used to be head of UNEP in Nairobi, an old friend. And again, Nancy Chege from the UN, my kind of partner in setting up this work. And so why go through the effort to add ethnomedicine as opposed to just saying this HETA project is going to be hard enough, because installing hardware is one thing, but sustainable management's another. And this came out of a whole variety of these conversations with community groups, not only in Kenya where we're doing the pilot, but also in the DRC. And I've mentioned our program is active, as well as in Rwanda. and most recently South
Goldman.
Sudan. So everything from,
Goldman, DRC
sorry, what was that?
was
Some feedback. Anyway, carry on.
Oh,
was the
okay.
size.
Someone I think saying DRC.
No, it's okay. Carry on, Dan.
Okay. Okay. So some of the things that have come up as interesting, important leverage points for the ethnomedicine or the herbalist supply chain is utilizing the equipment that many of the clinics have, and hopefully that are now more reliable, to be able to do quality assurance of ethnomedical compounds. Taking advantage of cold chain to store a variety of compounds. Here you see a freezer in one of the clinics. There's a ethnomedicine practitioner preparing herbs. You can see some of the materials in the bag, and then being stored in some of the cold chain facilities. Utilizing the advances in lighting and other efforts at the clinics. So that the traditional ethnomedicine kiosks can be supported. And here we have kind of a shot of one of the traditional ethnomedicine centers. Here's a young woman who is selling what she calls the concoction. I just love the version of it. And this is a mixture of medicines in honey that's the most common medicine sold for headaches and cramps in central Kenya. There's a lot on the supply chain side, but electric fencing around some of the ethnomedical gardens. We see an example here, keeping wildlife out of clinic areas. And again, entry points for education and training, some of the more standard things. And then as clinics have been built in the HETA program so far, the interesting feedback to the low price of solar is that greatly overbuilding the solar and battery side of clinics that 10 years ago was impossibly expensive is now actually quite inexpensive. So now we have clinics overbuilding quite significantly the amount of energy. Here we have an electric three-wheeler that gets charged up when there's excess power at the clinic. In this case, this is bringing a patient into the clinic. So there are some interesting features that, again, the electrification of transport world is kind of opening up. And then, of course, Wi-Fi for reporting patient records is a whole nother area that we're working on with three governments in particular. The Kenyan government, the Malawian government, and the Eswatini government are all involved in efforts to make health records confidential and directly available for even the lowest income individuals who have cell phones but not smartphones. So how can you do medical records on basic devices? Again, Impact is this ethnomedicine leader in Kenya that has been working with communities to do growing of ethnomedical plants, testing recommendations. A young mothers group in central Kenya. This is the Yaku community. This is a minority community, kind of fighting to reclaim and keep alive their language. And here we see the young mothers here explaining, and then the old men, the Mzee, as they would say, are outside watching, and they're talking about honey, both for commercial sales, but also as the vector for ethnomedicine treatments. And again, just a blow up of the woman selling these concoctions in a clinic, which is scheduled to be electrified and integrated into conventional or Western medicine. Project has started out kind of interesting way. Here are certificates that community members are issuing to traditional herbalists so they don't get marginalized as solar clinics come into the picture. And I'll just kind of end. I think I've gone on a bit too long there. So we are in phase one, which is funded now at about $600,000 to electrify 6 to 10 clinics. So just about 10% of all the clinics in the county to do both their own electrification, but also to be a test bed for all of the work needed to make the electrification, the T part, the reporting, useful and not a burden in this process. We can shake down some of the data on what are the operation and maintenance costs, what happens when refrigerators fail, what happens when reporting systems, solar panels fail at these clinics here. Phase two will be to do the full effort, all 135 or so clinics. That's going to require about another $11 million And this partnership has been out actively seeking that. We had fairly good meetings in Dubai at COP28. We do not have all 11 million promised. Some of it will come from that GAP partner, but certainly not all of it. And so we are in a process looking for partners to raise that. And I know I've gone on a little longer than you intended, but I'm going to stop there